Welcome to our podcast, Heart Failure Morning Commute, Decisions in the Management of Heart Failure. Morning Commute is developed in collaboration with At Point of Care and Projects and Knowledge and is part of a continuing medical education series. This independent CME-CE activity is supported by independent educational grants from Boehringer Ingelheim Pharmaceuticals Incorporated and Eli Lilly and Company, and from Merck Sharp & Dohme Corporation. In this episode, Dr. Deepak Bhatt and Dr. Javed Butler continue their discussion on heart failure therapies. When should therapies be combined, switched, or stopped? And they also talk about how the COVID-19 pandemic has impacted the treatment of heart failure. Some may surprise you. Information about the faculty and disclosures can be found at morningcommutepodcast.com/heartfailure6. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Bhatt is Executive Director of Interventional Cardiovascular Programs, Brigham and Women's Hospital Heart and Vascular Center, and a Professor of Medicine at Harvard Medical School, Boston. Dr. Butler is Professor of Medicine in the Department of Medicine at the University of Mississippi-Jackson. I am Candace Hoffman, Managing Editor of Morning Commute. Dr. Bhatt will begin our discussion.
David, welcome back. In the previous podcasts, we've discussed the foundational and new treatments for heart failure, but it all comes down to the patient in front of us for making the tailored treatment decisions that we really always ought to make. So let's talk about that and what we've learned in our practices. Perhaps we can just start with some of the basics for patient management, or maybe it's not that basic, how to deal with combination therapies, when to switch therapies, when to stop therapies. And prior podcasts, we've talked about foundational therapies, getting patients on things like beta blockers and ARNI and SGLT2 inhibitors and mineralocorticoid receptor antagonists relatively quickly. But how exactly would you advise the audience to do that in terms of using combination therapies? And when might they consider switching therapies? And if side effects or other issues come up, potentially stopping therapies, maybe the patient's ejection fraction improves. Is that a reason to stop? So these issues come up all the time in practice. What are your thoughts?
Yeah, so that's obviously one of the most important questions, right? Because it's about patient management, and there's a lot of layers here to sort of peel off. So let's start. So first, let's just think about how cancer doctors think about treating their patients. They say, well, you have a life-threatening disease. This is a combination that we need to use. They will sit down with the patient, tell them the patient's side effects. And of course, we should not make light of side effects, and managing them and avoiding them is really, really important. But the first order of business is to treat cancer, and then you manage the side effects. Unfortunately, we don't have that sort of a culture in cardiology, and even with sort of some slight reason to cut down or not give therapy, we just go ahead and do that. Not realizing that we are putting patients a little bit at risk for worsening heart failure, mortality, morbidity, and maybe management of these combination therapies really is important. So what can we do? I mean, these are really, really simple clinical tricks, right? So let's take one by one. You're dizzy, you have orthostatic symptoms. Well, make sure that you're not very dehydrated. Giving a little bit extra fluid in the vasculature may avoid that. Now, I don't mean to give IV fluid. What I mean to is that maybe you can cut back a little bit on their diuretic dose. Remember, ARNI and SGLT2 inhibitor both increase diuresis. So giving them a little bit more volume, cutting down on the diuretic may help. Your blood pressure is low. Well, your blood pressure is low or you're dizzy. Don't take all the medications at the same time. So along with managing diuretic, you don't have to take every medicine at 8 in the morning when you wake up, and then all the medicine hit at 10:30 in the morning. Maybe take one pill at 8 in the morning, take one at noon, take one at 3. Now it does complicate things a little bit, but one at a time, maybe it will be helpful. But not all patients will be able to tolerate the highest doses. But remember, low doses are really, really beneficial. So at least give low doses if you cannot give high doses overall. What about creatinine? Same thing. Work with the nephrologist, send the patient to heart failure cardiologist rather than not treating the patient. Nephrologists and heart failure cardiologists may have a little bit more self-efficacy, a little bit more infrastructure in the clinics to deal with these sicker patients, and may be able to enable therapy despite that. And again, cut down sort of the dose of diuretic. What about, heart rate? Well, of course, that's sort of a little bit of a simple one. That with beta blocker therapy, the benefit is largely when you get a heart rate into the 60s. So if your heart rate, is 66 at carvedilol of 12.5 BID, that's good enough. I don't feel any compulsion to go up on the dose to 25 BID. Hyperkalemia, this used to be a big issue, especially with MRAs. But now, again, we have these novel potassium binders like patiromer or sodium zirconium cyclosilicate that has clearly been shown to be very well tolerated, and they enable MRA use or RASI use across all the risk factors for patients. So CKD, diabetes, heart failure, high doses of therapy, aging patients, all of those things. So there is a lot of different ways. Now, some of these therapies actually enable each other. So if you give somebody who's congested, who may not tolerate beta blocker, well, start with an ARNI or an SGLT2 inhibitor. They will be less congested. They will tolerate beta blocker better. If somebody has hyperkalemia, we know the data that with ARNI and with SGLT2 inhibitor, they enable MRA use because the risk of hyperkalemia is less with SGLT2 inhibitor. So in other words, there's a lot of these tricks that we can do. So before we give up on the drug, we should at least try to do these things. And if we are unable to do it or we are uncomfortable to do it, refer them to a specialist. Most of the patients should be able to be on some therapy at least. The last point you said is, well, when do you stop the therapies? Now, this is a really difficult question because if somebody has low ejection fraction, you start them on therapies and their ejection fraction improves. What does that mean? Does that mean that their heart failure is cured? They don't have heart failure, so why take the medicines forever? Or does that mean that their ejection fraction is improved because of the therapy, and if you were to stop the therapy, their heart failure will get worse again? So we used to have all of us used to have our opinion, but now there's actually a randomized controlled trial called TREAD-HF that came out in Lancet that clearly shows that even patients who have stabilized, stopping therapy is not a good idea, because if you stop the therapy, not only there's a high risk for ejection fraction going down again, there's no guarantee that restarting the medication will improve the ejection fraction again. Do I completely religiously follow what I just said, that never touch the medication even if the EF improves? Well, not really, right? So you have to make some sort of individual decision. So if somebody is, 50-year-old and has heart failure, and I've started them on combination therapy, and they will live up to 75, and they'll take the medicine for 25 years. I feel bad about it, but I will not stop the medicine. But if somebody has a disease where the natural history is recovery, so if I have a 23-year-old postpartum cardiomyopathy patient who completely recovers, do you want to give this person drugs for 60 years of their life? Maybe not. I tell you, I don't stop all the medication. I really sweat a lot, but I cut back one at a time and keep repeating echo and make sure things are right, in the right direction. Maybe I don't stop all four and maybe just keep them on low dose ACE inhibitor beta blocker. I mean, there's sort of no guideline there. You kind of just sort of, for the lack of a better word, wing it based on the individual patient. But that's the kind of patient that I may cut back. But as a general rule, even if the EF gets better, you don't stop the therapy.
Yeah, I'm sort of that same mindset of don't rock the boat. Even before TREAD-HF, I sort of thought if the patient's tolerating it well without side effects, that's a key part of it. Why subtract therapies if they're not demanding that you subtract therapies? And I think now there's, as you mentioned, data to support that sort of common sense approach. I'm glad you mentioned the potassium binders, because I think spironolactone sort of got a bad reputation. Well, part of it's because of, fears of gynecomastia and I think appropriate sort of concerns, but part of it has also been the hyperkalemia. But the availability of potassium binders, I think, really does change the equation in their trials that are going on, looking at these agents even more closely in different applications. But I think they're agents that nephrologists are pretty comfortable with. I don't know that most cardiologists or even heart failure cardiologists, I don't know. Do you think that's a class of drugs that should be in our comfort zone, much like we're saying these days, SGLT2 inhibitors or drugs that heart failure cardiologists and perhaps even general cardiologists should be familiar with? Does that also apply to potassium binders or not?
Yeah, no, most certainly, right? So I think the difference between cardiologists and nephrologists is that nephrologists treat hyperkalemia. Cardiologists cause hyperkalemia, right? So there's a little bit of a psychological difference there between the two specialties. But also, let's see, there's some really good data coming out with finerenone, which is a non-steroidal MRA. And you really have no progestational side effects like gynecomastia and all that kind of stuff, and the risk of hyperkalemia is less. So the answer is absolutely yes. Before giving up on MRA, you have a lot of benefit from MRA, and before you give up on MRA, use these potassium binders. And in fact, both the cardiovascular and the kidney KDIGO guidelines are now recommending that before you cut down on RASI therapy, whether it's ACE inhibitor or with MRA, try these potassium binders. And these are not specialty specific, either cardiology or nephrology. These therapies should be used because really the prognosis get bad if you stop the good medical therapies.
Yeah, really wonderful points. So we talked a little bit about hyperkalemia, its management. Any other side effects that you want to mention with these different therapies and combinations of therapies that we haven't already covered? Maybe dealing with things like hypotension. I know that's been one sort of concern that has limited to some extent conversion of patients on ACE inhibitor or angiotensin receptor blocker to ARNI, where doctors are a little worried about what if hypotension occurs, how are they going to manage that, especially in an outpatient setting, where maybe in-person visits are a little bit trickier because of COVID. We'll come back to COVID. We have to talk about COVID, but anything else you want to say about management of potential side effects?
Yeah, so I'm glad you sort of reminded me. So in terms of the switching, honestly, unless and until there is a contraindication or there is a lack of availability, I think all ACE inhibitor patients at this point or our patients should be converted to ARNI if you have heart failure with reduced ejection fraction. And in terms of the hypotension, remember, it's a different thing that if somebody has de novo heart failure and you're starting ARNI and to see what happens to the blood pressure or to creatinine. But if somebody is on chronic ACE inhibitor therapy, a lot of that blood pressure or the renal effects with RAS inhibitor is sort of weaved in. Now, clearly, with the addition of neprilysin inhibitor, you have that risk goes up a little bit more. But we're talking about, if you look at the trial, the risk of symptomatic hypotension may be 9% versus 13%. I mean, it's not dramatically different. And again, those sort of the common tips that we talked about in terms of diuretic dose and spacing the medications and those kind of things really help in that sense. Now, there may be some niche side effects, and one can sort of go into those things. So, angioedema with ACE inhibitor ARNI, so especially give some good education to patients, especially the Black patients are at a higher risk for angioedema. So keep that in mind. If it is mild angioedema, if it is significant, then obviously you seek medical help. But even if it's mild angioedema, you just stopped it and that angioedema went away, or you maybe just took some antihistamine, just because it's mild angioedema, don't try the drug again. I mean, you basically have a contraindication and just don't use the drug per se. A lot has been made about beta blocker and depression or beta blocker and bronchospasm. But again, switching the drug from selective, non-selective, those things tend to get mitigated. And again, rather than totally compromising, at least giving low doses is still very beneficial. So most of the patients should be able to at least get some doses of these therapies.
Yeah, that's a really nice summary of a lot of different side effects that might potentially come up, but putting them in the proper perspective. So what about innovation in heart failure? There's just, I think we've covered in this series of podcasts, a lot of different innovations, but there's still more to come. So what do you think is really going to change practice in terms of drugs, in terms of devices, but also in terms of strategies, not just drugs and devices?
Yeah, so we're living in just sort of unbelievable times, and obviously, I'm in a mature stage of my career, but I can guarantee you that even before I retire, the way we practice medicine would have changed than even what we're doing right now. So, for instance, all the advances that are coming on with not only the genetics, but the microRNA therapy and targeting specific biology, pathophysiology, all the omics revolution that is out there and trying to better understand pathways and come up with different diagnostic. device therapies and how they can reshape the heart, recover the heart, prevent things from happening. And then the way we manage patients, I mean, the amount of remote data. Now, granted, we are not totally there how to exactly use these remote data, but I think a lot will be switching to the patients. I sort of say that the doctors and the nurses are sort of the coaches, but the patients are the players, and they will be playing the game more and more. We just need to educate them better to be so that they're better players. But there are so many things coming out measuring every which way the cardiovascular renal physiology non-invasively by either implantable devices, apps, or things that you wear on your body. And those things are directly fed right now to the clinicians, but eventually will be fed to the patients that they can adjust their medications. So targeted therapy, different ways of strategies to manage these patients, more devices. So there's a metaverse of medicine coming as well, and it'll be quite exciting.
Yeah, the metaverse in all ways is pretty exciting. Now, actually, it really died today on the stock market, but that's a separate story. But I think ultimately there is really going to be a role for everything that you mentioned. There's no question that wearables are going to change the management, not just of heart failure, but a variety of different conditions. I think already in invasive sorts of monitoring, I'm talking about for example, the pulmonary artery monitoring, the sensors for heart failure are in common use in many practices. We use them quite a bit to keep an eye on our patients, say, that are referred for Maine, but we can't see them in person as frequently. But I think the next step in that evolution is to go from the invasive implantation of those things to just wearables. So I think that revolution's already started and will accelerate in years to come, for sure, for heart failure, but other disease states as well. The final thing that I think it's probably worth covering is the issue of COVID-19. There's just no way we can go through these 6 podcasts that you and I have done together, where I've really enjoyed speaking with you and learned so much from you. I don't think we can end without talking a little bit about COVID. And for sure, in relation to what we were just speaking about, changes in heart failure management, I think COVID-19 has taught us a lot. I hope things that endure past the pandemic, assuming we get out of the pandemic, but past that time where things such as televisits and remote monitoring, I hope are here to stay for heart failure and other related disease states. I think it's very patient-centric. Patients don't want to always drive in to the physician's office or hospital. Sometimes they do want that personal connection, but sometimes they just as soon avoid the traffic and the hour-long wait in the doctor's office and so forth. So, what do you think about the impact of COVID on healthcare and heart failure in particular?
Yeah, so before I talk about COVID, there was a really important point that I completely missed to talk about, and that is when we talked about patient management and enablement and therapies and switching, is the importance of doing these things when a person is in the hospital. Not only are they at the highest risk, but there is actually a really good teachable moment. And for many chronic diseases, we know that the therapies that are started in the hospital have the highest chance of long-term adherence and compliance with, to the point that the European guidelines now have a class 1 recommendation to start GDMT prior to discharge from the hospital. Unlike an outpatient 15-minute visit where the person is there and have multiple complaints, now you have, 3-4 days in the hospital. Maybe you have some support with pharmacy and nursing. You can educate the patient and the family members. So really, let's not miss out on the opportunity in the hospital. Now, that brings us to this COVID-19 thing. So the COVID-19 saga has just been sort of really fascinating. One is that we learned how agile we can be if we wanted to be. So the processes that would have taken months and years in regular healthcare system, we just sort of bypassed all of these processes that innovation that would have taken a decade, we just sort of got there in a week, right? So televisits, phone calls, different platforms through electronic health record, video calls, FaceTime, whatever in the beginning that was allowed. Now, again, we should not take that lightly. There are HIPAA concerns, there are privacy concerns, and I think we will get there. But telemedicine makes a huge difference in patients. And what we have learned is that there is really no credible evidence that the reduction in hospitalizations and increase in televisits and decrease in sort of in-person clinic visit is related to or translated into a higher mortality for heart failure patients. So in other words, these alternate ways of managing the patients, which are much more patient-centric, you can still get pretty good clinical outcomes. And if you marry that with either home health laboratory or point of care testing at home, I think this will be the future, and we should try to embrace it and improve how we manage these patients remotely.
I absolutely agree with everything that you said. I mean, it's just really great sort of insights into the positive impacts of COVID-19. I'd be remiss in not, of course, acknowledging what a negative impact COVID-19 has had on the world, obviously, but on cardiovascular disease as well. A number of studies showing worsening of risk factor control. I'm sure there's going to be downstream consequences of that in terms of atherosclerotic and heart failure complications, also in other fields as well, cancer surveillance and so forth. And as well, I would have to acknowledge the incredible role that healthcare workers have played in this pandemic. I'm sure many of the folks in our audience have been on the front lines and dealing with the issues of COVID. Maybe even some are feeling burnt out from COVID, but I'd like to just acknowledge all the efforts out there in our audience of the healthcare workers. Well, Javed, it's been a wonderful discussion with you today on this podcast and the previous 5 podcasts. I would ask the audience if they're listening to this one, but they've missed any of the prior ones, to tune into those and see what sort of perspectives we might have shared with respect to heart failure. Before concluding, I just want to turn to you and see what final pearls of wisdom you might have for our audience, not just from this particular episode, but all our episodes, some take-home points.
Yeah, I would say that the heart failure landscape has changed. So for one, the best treatment of heart failure is prevention, and there's a lot of things that we can do to prevent heart failure. So please think about prevention of heart failure, whether it's blood pressure control, SGLT2 inhibitor, bariatric surgery, lifestyle modification. So that's one. The second is that keep heart failure in the differential diagnosis, because the symptoms are non-specific: tiredness, fatigue, shortness of breath. And while we rule out other things, please consider natriuretic peptide screening and appropriate referral for echocardiography, and think about heart failure in your differential diagnosis. That there are a lot of therapies that are available to our patients, and giving these therapies, at least at low doses, can substantially improve the outcomes for these patients. And if anybody is feeling uncomfortable, referring them to specialist centers can really change their natural history and the trajectory of the disease process. And lastly, be on the lookout. A lot of further innovation is coming. And Deepak, it's been an absolute pleasure to talk to you through these several podcast series.
Yes, likewise, a real pleasure. And I think you've summarized things well. And the key is you made a very nice point in one of the podcasts with heart failure. If you can prevent it, that's the best approach of all. And there are things that can be done with respect to lifestyle modification. So that's always the bedrock of what we should be recommending to our patients. But then beyond that, in folks that actually have heart failure, certainly lifestyle modification continues to have a role, but their medical therapy is important. And it's important to get that medical therapy started early and to escalate quickly. And that therapy should include agents such as the ACE inhibitors, angiotensin receptor blockers, now more recently ARNI, substituting for them in patients with heart failure with reduced ejection fraction. Beta blockade, of course, has been important for years. MRAs, mineralocorticoid receptor antagonists, really important, though underutilized part of that armamentarium. The SGLT2 inhibitors, really a big advance and a major role in heart failure that's going to continue to grow. And for patients that need therapies beyond that, we discussed vericiguat and what that can offer. So, those are important considerations in terms of the medical therapy. And then, of course, there's device therapies that we need to think about, things like ICDs and cardiac resynchronization therapy. But then in a referral practice, are patients at a point where they need to be referred on to a transplant center for consideration of transplantation and LVADs. LVADs, of course, have come a long way with durable LVADs and newer generations with lower rates of side effects and complications. Most recently as well, xenotransplantation has captured the nation and world's attention, and it's very likely that this is something that's here to stay, starting off with the pig heart transplant, but but I imagine that's going to extend to other organs as well. So very exciting time in heart failure. And hopefully this series of podcasts has given the audience a sense of that excitement. Thank you so much for tuning in.
Thank you for joining us today. Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/heartfailure6. Look for all of our podcasts on your favorite podcast streaming services.